Hi, welcome to Set Piece Medicine. Here we aim to create fun, stress-free, and high-yield medical tutorials to supercharge your learning. Let's get started. Today's topic is on dementia. Let's kick things off with a case study. Mrs. Johnson is an 82-year-old woman who lives alone at home. She was brought to the emergency department by her neighbor, who noticed that Mrs. Johnson seemed confused and disoriented. Upon arrival, Mrs. Johnson is unable to provide any history. The medical team learns via corroborative history from her neighbor that Mrs. Johnson has been forgetting things, repeating herself, and misplacing items for several months. She has also become increasingly withdrawn and has stopped participating in her usual hobbies and activities. How do you differentiate delirium from dementia?
In differentiating delirium from dementia, we may use the confusion assessment method, also known as CAM. The primary criteria for CAM is the presence of acute onset and fluctuating course of confusion and inattention of the patient. This is followed by one of either disorganized thinking or altered level of consciousness.
Now, Rachel, tell me, what is dementia?
Dementia is a type of acquired major neurocognitive disorder. According to the DSM-5 criteria, a major neurocognitive disorder is defined as the decline in cognition of one or more of the cognitive domains. There are two main types of neurocognitive disorders: major neurocognitive disorder, aka dementia, and minor neurocognitive disorder, in which cognitive decline does not interfere with function.
You mentioned cognitive domains. What are the major cognitive domains?
There are 6 major cognitive domains: learning and memory, complex attention, speech and language, perceptual motor function, social cognition, and executive function.
What are the different types of dementia that you know of?
There are many types of dementia syndromes. The most common are Alzheimer's disease, vascular dementia, frontotemporal dementia, and dementia syndromes associated with Parkinsonism, including Parkinson's disease dementia, dementia with Lewy bodies, multiple systems atrophy, and progressive supranuclear palsy. Less common causes of dementia can be caused from etiologies such as trauma, for example, chronic traumatic encephalopathy, infections, for example, HIV, Creutzfeldt-Jakob disease, and syphilis, metabolic disorders such as hypothyroidism, chronic alcoholism, vitamin B12, and folate deficiencies.
Excellent answer. How would you differentiate between the common causes of dementia?
Often, dementia etiologies are unclear, as there may be multiple possible etiologies causing the dementia. This is known as mixed dementia. Alzheimer's disease is the most common form of dementia, usually affecting patients above 65 years old. Vascular dementia can present post-stroke or in the absence of stroke. In the absence of stroke, there is progressive stepwise decline with prominent features of vascular disease on neuroimaging. They tend to have prominent impairment of executive function, compared to Alzheimer's, which frequently impairs memory. Frontotemporal dementia is characterized by the degeneration of the frontal and temporal lobes in the brain. This leads to prominent social, behavioral, and personality changes. Examples include disinhibited actions, apathy and a loss of empathy, and compulsive behaviors. It may also cause aphasia. Parkinson's-associated dementia is characterized by classic Parkinsonism features in addition to dementia. In Parkinson's disease dementia, cognitive deterioration frequently only occurs 5 to 7 years after the onset of Parkinsonian motor symptoms. In the other Parkinson's plus syndromes, the onset of cognitive deterioration may occur close to the onset of motor symptoms. Patients frequently have a rapid deterioration.
Okay, can you tell me what are the risk factors associated with dementia?
There are several risk factors associated with dementia. This can be classified according to modifiable and non-modifiable risk factors. Non-modifiable risk factors include age, gender, and family history. Firstly, older adults have increased risk of dementia. Secondly, females have higher risk of dementia. Thirdly, patients with family history of Alzheimer's or other dementia syndromes have a higher risk for developing the disease. Modifiable risk factors for dementia in general are similar to cardiovascular risk factors. This includes smoking, diabetes, hypertension, hyperlipidemia, obesity, and low levels of physical activity.
How would you quickly screen for depression in a patient?
I would use a PHQ-2 questionnaire to screen for depression. The simple questionnaire screens for symptoms of anhedonia and low mood.
What are the types of cognitive screening tests do you know about?
As an initial screening test, simple tests like the 10-item abbreviated mental test, AMT, can be used. However, for more comprehensive cognitive tests, one can use either the Mini Mental State Examination Test, MMSE, or the Montreal Cognitive Assessment MoCA test. The MoCA test is more sensitive to executive and language dysfunction.
All right, and what investigations would you like to order for a patient with dementia?
I would like to do blood investigations and imaging investigations. Blood investigations include a full blood count, renal panel with glucose, calcium, magnesium, and phosphate, liver function tests, thyroid function tests, and vitamin B12. Imaging investigations include an MRI of the brain, looking for generalized brain atrophy, and focal areas of atrophy, such as in the hippocampus and medial temporal lobe.
Is gene testing routinely carried out in the evaluation of dementia?
In general, gene testing, such as testing for a polypoprotein E, APOE, is not routinely carried out.
Great. Now, tell me what are some of the complications of dementia?
The complications of dementia can be broadly categorized into, firstly, behavioral and psychological problems, also known as BPSD, behavioral and psychological symptoms in dementia. Secondly, functional problems, and thirdly, social problems.
Okay, tell me what are the common features of BPSD?
BPSD features can be divided according to behavioral and psychological symptoms. Behavioral symptoms include, firstly, sundowning, secondly, agitation, thirdly, wandering, and fourth, sexually inappropriate behaviors. Psychological symptoms include, firstly, psychosis, for example, paranoid delusions, hallucinations. Secondly, mood disorders, for example, depression and apathy. Thirdly, sleep disturbances like insomnia can also be seen.
How would you manage a patient with Alzheimer's disease? Can you elaborate more about how you would treat a patient with BPSD?
Ideally, I would like to manage this patient with a multidisciplinary team approach. This includes doctors, nurses, neuropsychologists, social workers, therapists such as behavioral therapists, and most importantly, family and caregivers. As a medical doctor, it will be my role to prescribe the appropriate treatment for the patient, as well as the coordinate care amongst the different healthcare professionals, and to educate patients' family and caregiver on the disease. Management of dementia can be classified according to pharmacological and non-pharmacological treatment. Pharmacological treatment includes cognitive enhancers and management of complications. Cognitive enhancers include two major classes. Firstly, the cholinesterase inhibitors like donepezil and rivastigmine, and secondly, NMDA receptor antagonists like memantine. Complications of dementia such as BPSD are often treated with antidepressants and antipsychotics. For non-pharmacological treatment, this often includes the optimizing of nutrition, exercise, and participation of cognitive rehabilitation and occupational therapy. Treatment of BPSD is classified according to non-pharmacological and pharmacological management. Non-pharmacological management include reassurance, light therapy to attempt resetting of circadian rhythm, referral to behavioral therapists, consideration of adjunct therapies like music or art therapy, and education of family members about disease and how to cope with patients.
Does treatment with antipsychotics and benzodiazepines increase mortality in patients with dementia?
Yes, certain antipsychotics and benzodiazepines have been shown to increase risk of mortality. This includes haloperidol, risperidone, and olanzapine. If required, very low doses of quetiapine could be initiated as it has lower mortality risk compared to the rest of the antipsychotics.
Thank you for watching. We hope that you have benefited from this episode. It took a lot of hard work to put this video together. It'll mean so much to us if you could like this episode and subscribe to this channel. Take care and see you next time.